Good afternoon, everyone. Thank you for joining the session today. My name is Olivia Marquez, and I'm a team member with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. And today we will be discussing exercise programs for people with dementia. What's the evidence? So I'll just post up this consent slide first and give everyone an opportunity just to read through it quickly. So we will be posting webinar poll questions throughout the session today, and your participation in the questions is voluntary. The polling questions, your participation will be anonymous, and the polling questions, your participation in the questions will be accepted as an indication of your consent to participate. So we hope that this will increase engagement and stimulate discussion in the session today. Okay, so just to let everyone know that after today, the PowerPoint presentation will be made available on Health Evidence's YouTube and SlideShare account page. This will be made available within the next week, but perhaps closer to maybe 3 or 4 days. And the links for these will be posted in the chat section. So today we will be going to talk about this systematic review. And there's a link to the review that will also be posted to you in the chat section. You can actually click on the link today to view the health evidence summary for this review during the presentation if you want to follow along. The full text review is also available, and again, that link will be placed in the chat section. The Optimal Aging Portal has also done a blog featuring this review, and that blog link will also be posted in the chat section. So to start off today, this is our first polling question, and we're just asking, what sector are you from? So we'll just open up that poll question in a moment, and you can answer at the bottom right-hand side of WebEx. So are you a healthcare practitioner? Are you a other health practitioner? Do you work in education, research, government, policy analyst, or other? So once you have selected your responses, please click Submit. So I can see some of the responses coming in so far, and we have quite a few public health practitioners today and a few other health practitioners, and quite a few from other sectors. So thank you very much for your responses today. So just a few housekeeping issues first. Please use the Q&A and chat section in WebEx to post your questions or comments. We'll ask that you please send your questions or comments to all the panelists, or all the attendees, and not just to the host. But if you do, that's not a problem. We will still see the posts. Towards the end of the session, we'll have a question and answer period, and I will be able to read your questions aloud to our presenter to respond. You do not need to wait until the end of the session to post your questions. You can do so as we're going through. So for the best connection today, we recommend that you use a wired internet connection versus wireless. And if you do happen to have any connection issues, you can contact the 24/7 WebEx helpline. And that's, again, posted in the chat section and up on the slide here. So if you do have any issues, feel free to contact that number. For the best audio, so to listen through your speakers, you can use the Communicate tab at the top of WebEx and click Audio Connection. Okay, so we have our second polling question today. And we're just getting an idea of who you're joining today's session with. So are you by yourself? Are you with 2 to 3 other people? 4 to 5? Or over 5? So again, thank you all for your responses today. So we see quite a few people are just themselves, and we have a few who are with 2 to 3 other people. So that's great. We have some groups of people joining us today. So first, I'd like to give a special thanks to our health evidence team. There's a large team that helps to put together these webinar series and help to keep the health evidence registry current and maintained. So for those of you who may not be familiar with health evidence was launched in 2005. We're a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year access to over 4,400 quality-rated systematic reviews. We provide links to the full text of reviews, some plain language summaries, and podcasts where available. One of our main goals here at Health Evidence, in addition to making evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use evidence in their decision making. So to highlight some of what health evidence has to offer, we help to save you time. We provide relevant and current evidence. So we've actually done the work on our end to appraise each review and screen for relevance. We keep this registry current and up to date. We use a transparent process whereby you can actually see the quality assessment that's been done for each review, so you can see exactly where the quality assessment and rating came from for each review. We have a variety of support tools for EIDM available on our website, and users have generally told us that the registry and our website is easy to use. So we'll move on to a model for evidence-informed decision-making and in public health. So this slide here holds a diagram of 5 components that you can see. So traditionally, public health practitioners and decision makers do consider evidence about community health issues and local context, existing resources, and community and political climate in decision making about programs and policies. However, it's become more apparent that considering evidence about research may be more challenging to public health practitioners. So as such, the Health Evidence webinar series is designed to identify research evidence relevant to public health decisions to help you with your decision-making process. So the evidence-informed public health wheel that you see here on this slide illustrates the steps that are involved in evidence-informed practice. So the wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So today we'll hear from Dorothy and how she has worked through the first 4 steps from define, search, appraise, and synthesize. And we'll see how this will help decision makers with the remainder of these 7 steps in this process. So we'll move on to our next polling question here, which we'll open up. And we're wondering if you have heard of the PICO-S term before. So yes or no. We have a few people who say yes, they have heard of it, and actually even more who haven't heard of it. So we'll leave that poll question open for just a little bit longer. Thank you for your responses. So the PICO-S format is a way to structure your quantitative questions in a defined set using the EIDM. It involves defining the population or situation, the intervention or exposure, a comparison or other group that you're comparing something to, the outcomes, and the settings. So we'll move on to our first polling question here. And we're wondering, how often do you use systematic reviews to inform a program or service? You always, often, sometimes, never, or perhaps you don't know what a systematic review is, which is completely okay, and hopefully today will enlighten you a bit on what a systematic review actually is. So we see most people are saying they sometimes use systematic reviews. A few people aren't quite sure what a systematic review is, and that's great. We see a few responses who are saying always and often. So it is my pleasure today to introduce you to our presenter, Dorothy Forbes, who is a professor for the Faculty of Nursing at the University of Alberta. So just before we hand over the presentation to Dorothy, I'd like to ask your opinions first. So exercise programs improve health outcomes for people with dementia. Do you strongly agree, agree? Are you neutral, or do you disagree or strongly disagree? So again, thank you very much for your responses today. We're seeing a few people who say strongly agree, and just a few people say neutral. And we actually have no one who disagrees or strongly disagrees with this. Okay, so with that said, it's my pleasure. I'll pass the presentation over to Dorothy. Dorothy, thank you for joining us today.
Oh, it's my pleasure. I can't tell you how pleased I am to share this review with you. My background is in public health nursing, and I also then did home care nursing, and then, you know, got my PhD and went on to academia. But my passion is, of course, community nursing, and everything I do tries to inform and make life easier for those living at home, and those specifically those with dementia and their informal caregivers to be able to live at home. So I'm just thrilled. So I'll move this forward. Olivia, I don't see the arrows for moving it forward.
So at the top of the slide there, you might see the word review.
Oh, yes, I think I do. Yes, now, thank you.
That's
all
great.
Right. Okay, you've got me. I'm so glad you're there, keeping me on track, Olivia. Yeah, so first I want to acknowledge my review team. And you'll notice that two of them have the same last name as I do, Scott Forbes and Sean Forbes, and I need to confess that they're my sons. And they're both have their PhDs in kinesiology, so they inform my work from that perspective. As I've said, I'm a nurse with a background in community nursing. So together, I have brought them on because I think knowing how to do systematic reviews is really important for them. And I'm, you know, pleased to be sharing today this work because I'd like to broaden it as well. And Catherine Blake, she's at the University of Western Ontario, and she's been my project coordinator for many years, and I couldn't do what I do without her. She's just terrific. And Emily Thiessen is a former grad student of mine, and I always include my grad students on my systematic reviews because I think, you know, they in particular should know how to do a good systematic review to inform their own research. So we'll just move on. Oh, and I should as well acknowledge the Cochrane. This is a Cochrane review, and I've done many Cochrane reviews over the years since early 1990s, so a long time. And so I work closely with, there is a Cochrane review group that is affiliated with those with dementia and interventions that support them. So they are so supportive in the work we do. They have a full-time librarian, for instance, who does all of our searches for us, and they review our work and, you know, ensure that it's worthy of being published in the Cochrane Library. So their support is tremendous, and I do encourage people to do Cochrane reviews because of that. It's just state of the science, people who are supporting and helping other people do reviews, so lots of help there. Okay, so our particular review, and I'm sure many of you know this, that World Health Organization in 2012 declared dementia a public health priority, that because people are living longer, more people will be having dementia as they age. So it's going to be huge to try to support these people. In the coming decades, with the aging of the population, the number of individuals living with dementia in their communities will rise dramatically, affecting their quality of life and those around them. The burden on family caregivers, community care, and residential care services will increase substantially. And exercise is among the potential protective lifestyle factors identified as a strategy for treating the symptoms of dementia and delaying the progression. So that is why we have chosen to do this review over the years. So our questions are, do exercise programs for older persons with dementia improve cognition, memory and recall, activities of daily living, neuropsychiatric symptoms, and that's sort of fancy words, but it's challenging behaviors, depression and mortality, and do exercise programs have an indirect impact on family caregivers' burden, quality life, and mortality, and do they reduce the use of healthcare services such as going to emergency departments for both the persons with dementia and their family caregivers. So our approach, the studies we included, now ALOIS is a huge database. It includes Medline and MBase and all of the common databases, as well as government documents and public policy documents, all sorts of things. So it's a very comprehensive database. And the Cochrane Dementia and Cognitive Improvement Group that I work very closely with, as I mentioned, they have a full-time librarian who searches the literature every day for interventions that influence the care of those with dementia. So that is a tremendous support, because keeping on top of the literature worldwide, the ALOIS also includes, registries in Japanese and Chinese in all kinds of different languages. Iranian is included in that database. So it's very inclusive. And I feel really confident that if there's any research out there that addresses our review question, that they will locate it. All relevant randomized control trials in which older adults with dementia were allocated either to exercise programs or a control group, which we consider to be a usual care or social interaction activities. We're also included as control groups. So pretty broad criteria. And at least 2 reviewers, so 2 people on my team, independently assessed the retrieved articles for inclusion, assess the methodological quality, and I'll be talking about all of this in more detail in a minute, and then extracted data. So Cochrane is they're really the gold standard of doing systematic reviews. So this is a requirement that at least 2 people on the review team independently do all of the steps. Assessing which article should be included, and then assessing the quality of the articles. So we independently do that, then we come together and see if we've agreed. And if we don't agree, there is some discussion about, why we each chose what we did. And if we still can't come to an agreement, then a 3rd person on our team participates, and we end up, having to come to some consensus about that. And I must admit, we don't very often disagree. We've been working together for a team for many years, so, we're pretty comfortable with how each of us do things. But it is it is something that we do because it does ensure rigor in the articles and the data that we're extracting. Okay, so the analysis, the outcomes that we identify are usually related to continuous data. So we have are always really able to extract the mean differences between the intervention group and the control group, or the standardized mean difference between the intervention control group using continuous data. So I talk a little bit more about this in a minute or two, but data for each outcome were synthesized using a fixed effects model, unless there was substantial heterogeneity between the studies, then a random effects model was applied. Now, a fixed effects model means that there's no or very little heterogeneity, differences between the studies that we're including. And that was very, very seldom the case, because some of the studies included different levels of dementia or different types of dementia, or they used different interventions, you know, different kinds of exercise. They may have included resistance training with aerobic training, and others just included one or the other. So there was a lot of variation, and that's what heterogeneity means. It means variation between the studies. And you would have thought there'd be a lot of studies out there so that we could narrow down our criteria. For instance, I really wish we could just narrow down to looking at those with Alzheimer's disease or looking at those with vascular disease, because those kinds of dementia are really very different. But the research that's been conducted to date includes both types of dementia. So it's it causes problems because we can't tease out very well, what if the intervention is better for one type or another, or a particular type of intervention is better than another, aerobic as compared to resistance training, for instance. So we're at the very beginning of understanding all of this. But we do the best we can with the literature that's out there, and I think just highlighting to people what kind of research is needed in the future is important work too. So, we share our findings, of course, the best we can, but we recognize there are lots of limitations to this work. So feel free to ask questions about all of this if you wish, but yeah. And we also evaluated adverse events. So things, did people die? Or were people, did they develop muscular complaints? Or, were there complications from their involvement with this work? So we did try to capture that as well, because that's really important too. Not only the benefits of these interventions, but what were their harms in participating in these exercise programs. So we did try to do some subgroup analysis, so we did try to tease out, if people with more severe dementia the exercise programs had a better influence than people with a mild form of dementia. And the type of dementia, did it work better for those with Alzheimer's disease as compared with vascular disease? So we did that kind of subgroup analysis to try to tease out, what worked best. And we also tried to figure out, there was a huge variation, up to 18 months. Some of the exercise programs were conducted and others were conducted for just a few weeks. So, does the frequency, the duration, the type of exercise, aerobic, I think is sometimes better than resistance for people with Alzheimer's. But so we tried to tease all of that out to more thoroughly understand what was happening within these trials. Okay, so our librarian, she retrieved 5,241 titles and abstracts, which is huge. But we were able to quickly skim those, really. just from reading the titles and abstracts, and we decided that 542 abstracts seemed to meet our inclusion criteria. But when we independently looked at each of those articles, we decided in the end that only 69 articles actually met our inclusion criteria. But when we even further explored those articles in full and the kinds of methodology they used and the randomization and all of that, in the end we only retrieved 18 fully met our criteria and were actually included in the trial, in the systematic review. There were 17 trials, and one of those trials published their work twice. So they reported on different outcomes in 2 publications. So that explains the difference between the 18 and the 17 that were actually included. It's not moving forward, Olivia. Oh, there it goes.
Oh,
okay.
There it is.
Yeah, good.
Great.
All righty. So the included trials and studies then were published between 1997 and 2012, and we didn't have a limit on dates. Sometimes you do put a limit, but we knew there weren't many out there, so we were inclusive of any trial that had been published. And you can see that where they were published all over the world, which I always find fascinating because it just makes me realize how important systematic reviews are, because they're pulling together the literature from all over the world, and many of them might not realize that that each other are doing similar work. And we do tend to communicate with the authors quite often, if they're missing information that we need. Catherine on my research team, she works often many hours connecting with the original authors to get clearer information, how exactly did they do the randomization process, or your outcomes the numbers aren't adding up for us, so help us explain all that. So it's fun to connect with the original authors and from very different parts of the world. The participants the number of participants that were included on our review were over 1,000, which is, a good number. So there isn't a lack of work going on. And they were residents of nursing homes, residential care homes, psychiatric facilities, day care centers, and in their own homes. So again, the setting may make a difference. So I would really prefer just to do it on people at home as compared to people in residential care, because I think there are differences there even. But we only had 2 trials that were done at the home setting, and actually just our last review included the 2 home. Before there were none done in the home. So there are, I'm hoping that in the near future there'll be even more done in the home settings, because I think that's important to try to keep people at home. Okay, and the programs, as I mentioned before, they varied a lot, from 2 weeks till 18 months. So that's a huge difference. And just the length of the program can make a difference, right, in how effective the interventions are or not. So huge. But we do, combine them at the studies, and those that have done longitudinal studies, we will continue to combine them over time, see if over time it makes a difference, which is really important too. So the programs range from twice per week to daily, and from 20 minutes to 75 minutes per session. So again, huge variations in the frequency and the duration of the interventions. The exercises were combinations of aerobic, strength, and balance. So again, huge, huge differences there, because the effect of aerobic is quite different than strength or balance. But control groups were usual care or social contact. And we are finding that the more recent studies tend to use social contact because that, as a control, because that controls for the social influence, the socialization influence on the outcomes, which is important. Because I do feel the socialization is important too, but we're just looking at the exercise. So we're trying to tease out what impact does the exercise alone have on our outcomes of interest. So to give you a sense of the kinds of bias, now Cochrane reviews are very rigorous, and I also do other kinds of reviews, and I actually teach a systematic review course, and so half of that course is qualitative and half is quantitative. So I really value the qualitative components because they provide the context of the trials or the studies and, you know, provide lots of other good and different information. But Cochrane reviews are primarily randomized controlled trials. So they try to just include or at least evaluate the rigor of the trials that are included in a Cochrane review. So they assess the risk of bias, and they randomly assigning people to the intervention appropriately is really important. So we look at each article and how well that's described, and and we look to see whether they're randomized, how were people randomly selected, and how were they randomly assigned. And we make a judgment about that, and we include it in our review for each article that's included, each study that's included. We comment on this so that the reader who reads our work can make a decision about how rigorous each of those studies were that we included. So randomization is huge, that it's properly done. Blinding is another bias that Cochrane is concerned about. So were the people who were providing the intervention blinded to the intervention? And of course with exercise, it's pretty impossible. Those who are giving the intervention, providing the exercise program, you know, they usually know that they are providing the intervention that is of interest to us. So we still rate it as, you know, there is a high risk, but we do talk about, you know, it isn't possible really to blind the people who are giving the intervention unless you deceive the participants and deceive the people who are providing the intervention, which a couple of studies do. But it's difficult. So, you know, it's expected that there will be some bias there. But those who are measuring the outcome, the assessment, doing the assessment of the outcomes, we do expect that they be blinded, that they do not know which participants participated in the intervention and which did not participate. So they can be assessing, you know, the participants' cognition, for example, and not know. Hopefully the person won't tell them or it won't come out. But we're hoping that they have been blinded and they don't know which of the subjects participate in the intervention or not. And we do look to see that outcome data has been reported on most, you know, the more subjects that can continue in the intervention, the better, of course, because you always worry about those people who leave the intervention. You know, why was it? And if they do leave, we like the authors to comment to say, you know, that, you know, they weren't, it was due to their health, they had a stroke or whatever. We do like to see some reasons for the participants leaving the study. And so we look to see if that kind of data has been reported. And again, selective reporting, we don't find, all of the authors actually reported all of the outcomes of interest in their articles. If they didn't, and we have trouble going back, of course, some of the trials are registered and we can look at the protocols, what they plan to do, but that's not very often the case, that we can go back and look at the original proposal to see what they proposed to do and then determine if they actually did report it on the outcomes that they had hoped to. But as far as we can tell, from the limited evidence available to us, they tended to report on the outcomes that they had intended to examine, and other biases or other problems. Yes, so that's just to give you a sense of the rigor and how much we examine each of the studies to determine how much bias there might be in each, so that ultimately the person who's reading our Cochrane review can make a decision about the quality of the evidence and, you know, feeling more secure in their acceptance of our evidence or not. Okay, so our results. All righty, so 9 trials examined the effect of exercise on cognition, and 409 participants is a good sample. And the meta-analysis that we did then revealed no clear evidence of benefit from exercise on cognition. And I'll just share a little story with you. What I'm reporting now is our most recent Cochrane review, but 6 months before this review, we like to do it quite regularly. It's not, we don't usually do an update 6 months later. It's usually within 2 years. But we did an update after 6 months. So 6 months previous to this review, we did find that cognition did make a difference. And then we included one dissertation, a PhD dissertation, which we evaluated as not well done at all. But Cochrane is quite, you know, even if it's not, because we report very clearly on the quality of each article we include, we still include articles that were poorly done. But I had a real ethical dilemma, because when we included this article, cognition was no longer significantly important in contributing to dementia, in reducing. Exercise was shown as no longer contributing to cognition. So it was very disheartening, because 6 months ago we had found that there was cognition. It made a significant difference in cognition, and it just went viral, that systematic review. And I had interviews from all over the world because it's such good evidence and knowledge. And now we've come out to say that it doesn't make it. But I'm sure that when we do our next update, I'm, you know, almost positive that with other good studies that we will be able to say with confidence again that exercise makes a difference in cognition. But at the moment, we can't. So, yes, you can see that it was above the 0.05. The p-value was above, so it was no longer significant. And there was substantial heterogeneity, 80% of heterogeneity. I-square value is what we use. So the quality of the evidence remained very low. So people need to take that into consideration for a variety of reasons, yeah. So ADLs, so exercise has consistently shown that it does improve activity of daily living. And so we're very confident in saying that we have found a benefit of exercise programs on the ability of people with dementia to perform activities of daily living. There were 6 trials and 289 participants included in that analysis. And so the p-value was, you know, lower than 0.05 quite a bit. So with confidence, I can say that exercise does improve activities of daily living, which is a very, very important outcome. There was, though, unexplained heterogeneity. It wasn't quite as high, you know, the variability between trials. So the quality of evidence was very low. But even with all of that happening, we still got a significant effect. And I'm sure when we get more work done in this area and we can decrease that heterogeneity by just combining, you know, certain types of dementia or certain types of interventions. It will even be stronger evidence. But that's where we're at the moment. And the outcomes that were of interest to us, one study suggested that caregiving burden may be reduced by supporting the person with dementia to participate in an exercise program. So that's very limited evidence. It's just one study, but it makes sense if the person with dementia is, you know, able to do more in terms of their daily activities, that the caregiver would feel less burdened as well. So this is very, very important too, because often the caregiver ends up in hospital before the person with dementia. It's a huge, huge burden on these caregivers. So if there's something that we can do to decrease that burden, you know, it's so valuable. And there was no evidence of benefit of exercise in neuropsychiatric symptoms, such as, you know, the challenging behaviors, the aggressiveness, or the acting out, or the repetitive behaviors, or on depression. But again, you know, the evidence is just, I don't think, there yet. But we have, you know, there definitely is no clear evidence to date, but I'm hoping that we'll be able to demonstrate some benefits later with better evidence. Okay. And the remaining outcomes could not be explained because appropriate data were not reported. So quality of life for both the person with dementia wasn't examined very often, and for the person and the caregiver either, and mortality wasn't examined for either, and healthcare costs. They weren't outcomes that we could find in the literature, and I think these outcomes are important, and hopefully in the future we'll be able to find some work in this area. Okay, so in summary, the review included 17 trials. Our first review only included 4 trials, so there are more over time, with over 1,000 participants. The exercise programs vary greatly, as I've said, and the review suggests that exercise may improve the ability to perform activities of daily living, which is really important. There was no clear evidence of benefit from exercise on cognition, on the challenging behaviors, or on depression. So recommendations to improve the methodological quality. In several cases, usable data for inclusion in the meta-analysis were not provided by the authors. So we needed a means and standard deviations of at least the endpoints of the intervention group and the control group to do our analysis. And even though we contacted the original authors at least 3 times, and yeah, if we couldn't get that data, then we can't include their work in our analysis, which is unfortunate. And there were 4 trials, I think, that didn't report the data that we needed. So authors should include the means and standard deviations for the endpoint measures, and change from baseline to final measurement scores in the published report. So we can use either. We can use endpoint, or we can use the change in difference from baseline to final measurement. So if they reported any of those, that would be great. Be willing to provide these data on request, and if they don't report it, we'd really appreciate it if they provided it when we asked them to. Quality of the evidence. Many authors did not adequately report the random sequence generation and the allocation concealment. So how do they actually do that randomization process and conceal, you know, so that people didn't know if they were being assigned to the intervention, the intervention or the control group. Several authors did not report the outcome data for each main outcome, which is disheartening, and some authors failed to report on the blinding of the outcome assessors. So these are pretty basic things that we need, information that we need to be able to conduct our review appropriately and completely. Implications for practice. No trials reported adverse events related to the exercise program, so that's really encouraging, that exercise doesn't do harm if people are appropriately protected and, informed. Healthcare providers should feel confident in promoting physical activity to persons with dementia. Yeah, I am a strong believer that exercise is important in decreasing the progression of dependence and activities of daily living will have clear benefits for the persons with dementia and their caregivers, and possibly delay the need for placement in long-term care settings. So the longer they can carry on being as independent as possible in their activities of daily living is both beneficial to the person with dementia and their caregiver. Encouraging caregivers to participate in exercise may have a beneficial impact on their quality of life as well, which was a really interesting and important outcome that we discovered. Implications for research. Setting of the intervention, whether the home or the institution, should be considered in the future. And as I said before, I think I would really encourage more work to be done in the home so that we can, clearly demonstrate the effects early. The earlier people get involved in exercise, the better, of course. So waiting until they get into long-term care facilities is good, but, much more can be done. The sooner the better. There were insufficient trials to conduct subgroup analysis to determine which type of exercise, so aerobic, strength, or a combination is best. At what frequency and duration is most beneficial for specific types and severity of dementia. So, much more work needs to be done in this area to tease out. I suspect aerobic is probably better for Alzheimer's, but who knows? So it is important that we tease out exactly which kind of exercise works best for which kind of dementia and at what stage of dementia. Further research is needed to develop best practice guidelines for healthcare providers to advise persons with dementia living in institutional and community settings. So, yeah. All right, so our protocol was first published in 2007, and we've been updating it ever since. And I think that's it for me. But I'm pleased to answer any questions. Yes, so do you want me to move the ball?
If you could, that would be great, Dorothy, so you could just
okay.
Before I get back to the health evidence post.
Right.
So in the meantime, thank you very much, Dorothy, for that very enlightening review of the findings from your review, particularly your comment about the previous review that you did 6 months prior to this one. Very, very interesting.
Mm-hmm.
So we have 2 polling questions now, and then we'll open up the session for questions from the audience. So first polling question.
I'm having trouble moving that ball, Olivia.
Oh.
I can't get it down to you.
I think if you click and hold on the ball and then drag it up to my name, health evidence.
Yeah, it's right below me, but, jeepers. Oh, here we go. Okay,
there we go.
It's there. I must have tried 20 times. Good. Okay.
Great. So for our 6th polling question here, we have, do exercise programs improve health outcomes for people with dementia? And we'll just open up that polling question. So do you strongly agree, are you neutral, or disagree? So we've had a few people say strongly agree, and actually no one has said neutral or disagree to this question, which is great. So, Dorothy, I'd like to ask you, what would be your response to this question?
I would say agree.
Great.
Just because, yeah, the evidence isn't that strong, for the reasons I've described, yeah.
Thanks for your response. So we'll move on to our last polling question here. So do you agree with the findings of this review? So strongly agree, neutral, or disagree? So again, thank you very much for all of your responses today. And we have a few people who are, most people agree with the results. We have a few who are neutral, and we have about 2 people who say disagree. So it'd be interesting to hear their questions or comments throughout the session. So now we'll open it up for questions from the audience or comments that you have for Dorothy. So I will screen through them, and then I can read them aloud to you, Dorothy.
All right.
So we invite anyone to continue to post questions in the chat or Q&A section of WebEx. So I'll try to go through these in order as much as possible. So we have one comment from Ben, who said that your presentation is very interesting. So I think I just, he says that his therapists presently do not undertake these types of activities with dementia residents in their long-term care centers, and wondering if you have any tips to get them to adhere.
By therapist, does he mean rec therapists? I wonder.
So we can forward that to Ben and see if he has a response, what kind of therapist he's referring to there.
Yeah. Well, maybe while we're waiting, I can just add that, you know, I would strongly encourage exercise programs within long-term care facilities. Even walking, you know, is just moving about, and even those people in wheelchairs can do some forms of exercise, you know, tossing a ball from one person to another, or, you know, lifting their legs and arms and that sort of thing. So yeah, there's no restriction. Yeah.
That's great. So we have, Ben's actually responded here and said,
yes.
So looking for any tips to get therapists to adhere to these programs, and he's referring to physiotherapists and leisure therapists.
Okay, yes, good. Yeah. Well, sharing the evidence is definitely a strategy, and Cochrane reviews are accessible to everyone, so feel free to share this work with them, because there aren't harms in doing it, and there is potential of, you know, not only being more physically active, but potential for other outcomes like memory and that sort of thing. So just, I think, sharing the evidence and encouraging them that, you know, it does make a difference in their well-being, too, their overall well-being. You know, their feeling of being able to do more and to feel better about themselves. It's really important.
That's great. Thank you, Dorothy.
Yeah.
So we have actually 2 questions from Mark Andrew. So the first one is asking if you did any subgroup analysis, for example, the severity of dementia in this review.
Yes, yes, we did. But because, yeah, we did, but nothing was clear. And it was primarily because we just didn't have enough studies and participants, even though it seems like a large number when you start breaking it down to each kind of, you know, activities of daily living or cognition or, you know, different outcomes. We did severity of dementia, so severe, mild, and moderate. We did different types of dementia, vascular dementia, Lewy bodies, but because our numbers were quite small at that point, and because of the other heterogeneity, we weren't able to make any conclusive, you know, conclusive outcomes or conclusive recommendations based on that. But this is something we continue to do, and I'm hoping that with more studies and more rigorous studies that just include certain types of dementia and certain levels, perhaps, severity, we will. I mean, this is really important that we do try to figure out what kinds of exercise are important for which kinds of people at which stage. Yeah. So a good question, but there isn't enough evidence out there to make recommendations at this point.
Thank you, Dorothy. That's great. So the next question, or second part of that, was, is there any way to give less weight to studies that are deemed to be of poor quality?
That's a really good question. Yeah, Cochrane doesn't, but other kinds of systematic reviews do. And they actually, cannot include studies that they feel are not up to quality. The author of a systematic review makes those decisions. So you definitely can only include ones that you think are appropriate and of good quality. So definitely, but Cochrane review tends to be inclusive and leave it up to the reader. The Cochrane review includes all kinds of information about each study they've included and rated them and that sort of thing, like with the bias, it's quite clear where the bias is coming from. So they leave it up to the reader to decide, okay, if we left that study out, the evidence would be stronger, that sort of thing. But so we have to include everything in Cochrane, but other kinds of systematic reviews, the authors make decisions about that. So it depends on which kind of review you're looking at.
That's great. Thank you, Dorothy. That's a great response, considering there was, I think that piqued a few people's interests.
Yeah.
So I have another comment from Ione who says, thank you for the very interesting presentation. Says, I think it will be important to differentiate between vascular causes of dementia and other. So perhaps when we look to benefits of exercise and dementia in the future.
Yep, I completely agree too. Yep, because vascular dementia presents very differently than Alzheimer's and the other dementias. And, the parts of the brain are, with vascular, it can impact, different parts of the brain. Alzheimer's is quite specific to a certain part of the brain. So they're very different diseases. And so we shouldn't be lumping them all together because, our brains work differently. And, yeah, so again, we just need more work in this area so that we can do some subgroup analysis and just include those with Alzheimer's and just include those with vascular and see how exercise affects those particular kinds of dementia. Yeah, I completely agree. It's important.
That's great. Thank you. So we have another question from Jane who's asking, are there best practice guidelines available at present? She's saying that she would like to work on these if there isn't.
Oh, wonderful. Because there isn't for dementia. There is for older adults. There are some very good guidelines out there. McMaster has done some work in this area, or the Center on Aging from Western too. I think it is. Yeah, so there's been work for just older adults and very good guidelines, very specific guidelines, 120 minutes per day of aerobic or 3 times a week for aerobic, that sort of thing. But there isn't for those with dementia, just because the evidence isn't clear enough yet, I believe. That's why we haven't developed some guidelines. But it's definitely needed, so needed. But we're hoping in the near future we can be confident enough to provide guidelines in this area.
Great, thank you. And we have another comment from Monica, who's mentioned that gentle, persuasive approaches is another great course to take to develop skills to work with dementia, and that also music motivates people with dementia.
Yes, yeah, they are very good approaches as well. So yes, I agree.
That's great. Yeah. And we have another question from an individual who said, I'm curious whether there are any longitudinal studies where they looked at disease progression and those who were physically active or regularly exercise I wonder about the doses of exercise and whether they were suboptimal, that is either intensity or duration.
Yeah, I agree with that too. So we did include studies that were quite intense and, you know, every day, but we also included studies that, you know, were 2 times a week for 20 minutes. So there's a huge variation out there. So because of that, you know, we're not able to tease out again, you know, what is the best frequency and duration and intensity. Those questions are all still unknown because of the lack of being able to combine studies that are the same in those areas. We've only been able to combine studies at great variation. So there's just not enough research out there to be able to tease that out either. But important, really important, because we need that kind of information to develop the guidelines. Yeah. So anybody interested in doing some reviews? Yeah, lots of work in this area. Yeah. Yeah.
Okay, so we have actually a comment from someone who's saying, in the webinar, Engaging the Aging, the presenter stated Bob Levenshire from the UK asked the question, people 65 years and old and older, if your life depended on it, would you exercise? And the answer was that only 30% would exercise if their life depended on it. I'm wondering if you have any comments on this.
Wow. Wow, that's amazing. Yeah, I just personally feel how important exercise is for older adults and particularly those with dementia too. It just, in so many areas, there are benefits, so many benefits from exercise. You know, your well-being, your quality of life, your muscle tension, and yeah, your breathing and all of that. So I can't imagine that only 30% felt that it was of value. It's just, I don't know how many times I've said this, but yeah, we just haven't been able to demonstrate it. But personally, I would never tell somebody not to exercise because the research wasn't there. I say, you know, it's not going to do you any harm, so do it, because it probably will have lots of benefits that we can't demonstrate yet. But it's definitely of importance to exercise as long as you can, even from a wheelchair.
Certainly very interesting. So just expanding on that, wondering if you have any comments or what do you think are barriers for older people to engage in exercise?
Yeah. Well, sometimes it is limitation. You know, they are confined to a chair or they, you know, they are confused or disoriented or so health or in pain. Yeah, so there are symptoms that can limit to some extent the ability to do exercise. But with the proper supports and proper treatment, you know, the proper treatment for pain or that sort of thing, and, you know, to help people orient and to help them to do the exercise. I still encourage at all levels the importance of exercise. Yeah.
For sure.
Even if it's walking. Yeah, walking is very good. If they can, with support.
Thank you very much for your response. That's great. So
you're very welcome. Yeah.
I'm not seeing too many more questions or comments posted, so I invite you to continue to post comments or questions in the chat or QA section. But in the meantime, I'll carry on with these slides. So moving on, I'll bring us back to the model of evidence-informed decision-making. And Dorothy has certainly brought to light the purple research section of this diagram and what currently has been shown to be effective with exercise programs for people with dementia. And you've certainly highlighted, Dorothy, the importance of critically going through these reviews to identify what is effective and what is not effective. And we'll also highlight that, you know, the size of the circles in this diagram may change depending on the decision that you're making. So sometimes that research section may be larger or smaller, or some of the sections may be larger or smaller, depending on what sort of decisions you're making and what context you're in. So I'd also like to provide or extend an invitation to everyone today about a new study that we have here brought to you from Health Evidence. So supporting awareness and uptake of cancer prevention knowledge in practice. And this study is funded by the Canadian Institutes of Health Research. So this is an 18-month study. So we're recruiting Canadian public health professionals who use research in program planning decisions. So we're inviting them to receive concise, actionable messages based on high-quality, systematic review evidence through Twitter, webinars like the ones that you've attended today, and tailored email messages. So there's a link on the slide here, which you'll also see in the chat section if you would like more information about this study. And I'll also leave you with a call to action slide of what you can do now. So we invite you to visit the website where we have a free repository of over 4,400 quality rated systematic reviews related to public health interventions. And we invite you to register on Health Evidence to receive monthly tailored emails updating you on new reviews that have been added to the registry, as well as our monthly newsletter to keep you up to date on events such as upcoming webinars in our monthly webinar series and information about public health news. We invite you to share Health Evidence with your colleagues and follow us on Twitter at Health Evidence, where you can receive daily public health review-related tweets and information about our webinars and other events. We encourage your organization to use Health Evidence, and of course we invite you to contact us at any time to suggest review topics that you would like to see featured in our webinars or provide any other feedback. So I'll just take a look, and I'm not sure if I'm seeing any more questions or comments. So we can still invite you to keep posting in the Q&A or chat section. Okay, so with that, we thank everyone for joining us today. So again, a copy of the presentation will be made available, and you can use the links that are posted in the chat section on the side, and you can contact us at any time with ideas for future webinar sessions. So I'll hand it off to Dorothy if you have any last comments that you would like to share with our audience today.
Yeah, I just want to thank you for this opportunity to share our work. It's wonderful that there's such an interest. So it makes it all the hard work worthwhile. So thank you all.
For sure. Thank you very much, Dorothy. We are so happy to have you present your findings today, and we're very appreciative. So on behalf of Health Evidence, we'd like to extend a great thank you. And just to let our audience know, Dorothy and I will likely stay on the line after the presentation, but we thank everyone who has joined us today and wish you a very